This is the second video on a series of 5 videos on inflammatory bowel disease, and we'll discuss ulcerative colitis. Ulcerative colitis can affect any part of the colon, and the rectum is usually involved. Common symptoms are diarrhea, blood in stools, stomach pain, and fever. It can also cause disease outside the colon like skin lesions, joint pain, mouth ulcers, red eyes, liver disease, and increased risk of blood clots. Blood tests done include full blood count, liver test, kidney test, iron, vitamin D, and calcium. Blood test called CR protein, which measures the degree of inflammation. Stools culture for bacteria and parasites, as food poisoning may have similar symptoms. Stools for calprotectin, which measures the degree of inflammation of the colon. And finally, colonoscopy. Colonoscopy is a procedure where a thin flexible tube with a camera is inserted through the anus and gently pushed in to visualize the entire length of the colon. Colonoscopy is to look for changes in the lining of the colon that is suggestive of ulcerative colitis. Also, tissues of the lining called biopsies are taken and examined under the microscope. This is an image that shows how ulcerative colitis looks at colonoscopy. Ulcerative colitis can be classified as mild or moderate versus severe depending upon the following criteria. Ulcerative colitis can only involve the rectum, extend up to the sigmoid colon, and finally can involve the whole colon. Usually, the greater the length of the colon affected, the more severe the condition. Severity of inflammation according to frequency and severity of diarrhea, presence of symptoms like fever and weight loss, and laboratory abnormalities. A score called the Mayo score can be used for assessing the severity of ulcerative colitis. Presence of disease outside the colon signifies more severe disease. Low or high risk patient for complications according to the criteria listed below. The objective of treatment is to ensure that there is complete healing of the inflammation of the colon as confirmed by endoscopy, and patient feels normal again with no symptoms. There are two aspects of management: treatment for the first time at presentation and treatment at relapse or flare-ups. Secondly, maintenance of remission. Medicines are used to suppress the immune system and inflammation, and thus reduce the abnormal inflammation that is causing symptoms. It will relieve symptoms and also allow the intestine to heal. In maintenance of remission, the objective is to stop the inflammation from coming back. Let us now discuss drugs used to treat mild to moderate ulcerative colitis at presentation, for the first time, and for relapse or flare-ups. There are basically two types of drugs used to treat mild to moderate ulcerative colitis. One is called mesalamine or 5-aminosalicylic acid or 5-ASA in short. This drug suppresses inflammation, and this drug is the first drug of choice for mild to moderate ulcerative colitis. The second group of drugs are called steroids. These drugs act by suppressing the immune system and have serious side effects if used long term. This drug is used if the patient does not respond or tolerate mesalamine. So these are drugs of second choice in mild to moderate ulcerative colitis. Both mesalamine and steroids can be administered in two ways. They can be given orally in the form of tablets, or they can be given in rectal form in the form of suppository or enema. If you can imagine that this is the colon in green. These medicines can be given rectally in different forms. Suppository is used if the disease is limited to the rectum, as noted here. Foam and gel is given if the inflammation extends further up to the sigmoid colon. Liquid enema is given if the inflammation extends all the way up the descending colon up to this level. Liquid enema can travel the furthest up the colon, but is also the most difficult for the patient to retain. Gel enema is better tolerated than foam enema, which is better tolerated than liquid enema. So, how the medications are administered and in what form rectally depends upon the extent of the inflammation or colitis. Ulcerative colitis can be classified into 4 types depending on the location of the inflammation. If it only affects the rectum, then it is called ulcerative proctitis. If it affects the sigmoid colon, then it is called proctosigmoiditis. If it extends up the left side of the colon, that is the descending colon, then it is called left-sided colitis. If it extends to involve much of the rest of the colon, then it is called pancolitis. Management basically depends on which part of the colon is involved. Let's now discuss the management in greater detail of ulcerative colitis, which is mild to moderate. Let us now look at the image of the colon. If the disease involves only the rectum, the first choice is a mesalamine suppository only. If it extends further up and involves the sigmoid colon, then gel or foam mesalamine enema can be given. If it extends beyond the sigmoid colon up the descending colon, then mesalamine liquid enema plus mesalamine oral tablets are given. They are given together. If there is no response to the mesalamine enemas or the mesalamine suppository, then rectal steroids are given. If this doesn't work, then oral steroids are given. If mesalamine liquid enema and oral mesalamine doesn't work, then one switches to oral steroids. Similarly, for ulcerative colitis affecting the rest of the colon, the initial drug used is mesalamine liquid enema and mesalamine oral tablets. And if this doesn't work, then one switches to oral steroids. Steroids are usually given for a maximum of 8 weeks and stop because of side effects if used on a long-term basis. Improvement in symptoms with medications are usually seen in 2 to 4 weeks, with maximum improvement seen in 12 to 16 weeks. This table summarizes the management of ulcerative colitis mild to moderate. This table shows drugs that are used in severe ulcerative colitis or patients with mild and moderate ulcerative colitis who do not respond to treatment. Drugs used include intravenous steroids, high-dose oral steroids, drugs called immunomodulators that suppress the immune system, and biologics. They are antibodies that target or block and neutralize certain proteins that are involved in the inflammatory process. Normally, immunomodulators and biologics take a couple of weeks to be effective. So, in the interim period, steroids are given as the onset of improvement is a lot faster. This table shows drugs that are used in maintenance therapy of ulcerative colitis. All patients are put on maintenance therapy except for those with only involvement of the rectum called ulcerative proctitis. Only those with ulcerative proctitis and more than one flare-up per year are put on maintenance. Symptoms during flare-up include abdominal pain, diarrhea, and blood in the stools. Maintenance therapy is important as recurrent relapses can result in severe colitis and sometimes surgery to remove the whole colon. Drugs used include mesalamine, oral or enemas. If one is unable to maintain remission with mesalamine, then drugs called immunomodulators and biologics are used. Long-term side effects of immunomodulators and biologics are less than steroids. Steroids are not used as maintenance therapy because they do not prevent relapse and also due to the high incidence of side effects. As I mentioned, relapses increase the risk of life-threatening complications which might require surgery. Ulcerative colitis increases the risk of colon cancer after 8 to 10 years of the disease. Hence, colonoscopy should be done 8 years after onset of symptoms and repeated every 1 to 2 years. Patients with ulcerative colitis only affecting the rectum, also called ulcerative proctitis, probably do not have an increased risk of colon cancer.